So thank you, Dr. Sutanshu, for keeping me in this course, and it's really because it's always the honor to be in this course with you, with stalwart speakers, Dr. Kamal, and so many other speakers. So thank you very much for this opportunity. So today I'm going to talk about the phacoemulsification in difficult small pupil and floppy iris syndrome. So we have no financial interest in the subject matter of this presentation. Friends, we know that performing surgery in eyes with a very small pupil makes every step of the procedure more difficult and problematic. The reason for that is because the small pupil reduces the visualization, it limits the size of the capsular axis, it restricts the hydro procedure, and finally it limits the nuclear manipulation, because if I have a small pupil and a small axis, the nuclear manipulation becomes very difficult. And along with the nuclear manipulation, you have a difficulty in the aspiration of the cortex, epinucleus. You have a difficulty in the rotation of the nucleus, because all these points would come across if you have a small pupil. And if you continue with a small pupil, the phacoemulsification, it increases the risk of potential complication. And these are the complications, the important complications. You may get into the posterior capsular rupture, vitreous loss, and zonular dehiscence, and so many other problems. So the question arises, what is the critical diameter for the pupil to be considered as a small? So any pupil which is 3 millimeter or less than 3 millimeter is called as a small pupil, should be called as a small pupil, because this is the size of the pupil where your manipulation in the capsular bag would become very difficult. And pupil which is 3 or more than 3, like say around 4 millimeter of the pupil, 4 millimeter, some way like it's quite sufficient to continue the surgery. Like you can get a capsular axis of 4 millimeter. If you get a 4 millimeter capsular axis, it becomes easy to manipulate the nucleus within the capsule. So what are the causes? Like, why do you get the small pupil? There are several causes, and these are the important causes are like age-related, where you get the iris atrophy. You have pseudo-exfoliation, then you have dilator atrophy and the sphincter atrophy at the same time, metabolic pupillary defect, like you get a rubiosis and all these factors, and then the posterior synechia or the synechia induced with the uveitis, ankle closure glaucoma, and previous surgery also. These are the important factors for the pupil to be small and makes your surgical procedure difficult. But one of the very important cause is IFIS, that is intraoperative floppy iris syndrome. This is a dilator atrophy, or dilator atony, rather you call it as a, and this is characterized, like this syndrome is characterized by the poor dilatation of it. Like whatever you use all these mydriatics, you use intracambrian injections, whatever you use, pupil does not dilate beyond 3.5 to 4 millimeter. And another important point within this situation is if your pupil, like the moment you start the surgery, you start the irrigation in the anterior chamber, pupil starts getting constriction, like intraoperative progressive myopia. So this is another important problem. So these are the two important characteristics of the intraoperative floppy iris syndrome. And this has been, like this problem has been associated with the long-term use of the alpha adrenergic antagonist agents. The most commonly used agent is the Flomax, that is tamsulosin, which is used for prostate disorder. And since this drug is a antagonist of the alpha agonist antagonist, it relaxes the dilator muscles, and finally, because the long-term use of this drug makes the dilator muscle atrophic and atonic, so that it does not respond to any kind of dilating agents or the mydriatics. So what is the characteristic intraoperative presentation of this syndrome? Intraoperatively, you'll get a floppy in a floppy iris. The moment you start the irrigation, the iris starts billowing in the response to the normal irrigating current in the anterior chamber. That is one. Second is there would be a marked propensity for the iris to prolapse through the phaco as well as from the side port incision. So this is the second important feature. And lastly, the progressive pupillary meiosis. So if you get all these factors, your surgical procedure becomes very difficult. So what should we do before starting the surgery, actual surgery? What should we do? You should stop tamsulosin or the Flomax at least a month before the surgery, because if you stop a month before, then only it will be effective. You have to stop a month before. The another important point is always dilate the pupil at least 3 days before, because the same day dilatation won't work many times, because you have to dilate them at least 3 days before. And dilatation should be done with the atropine and the NSAIDs. So that is the rule, like if you are suspecting floppy iris syndrome. Then next important thing, what we can do is we can give intracameral injections nowadays available. The preparation of the tropicamide, phenyl, ephedrine, ketorolac, and lignocaine preparation is available in the form of omidria, midraine, phenocaine, and episugarcane. So these are the preparation available which you can use during the surgery or before you start the surgery, intracameral injection. Your incision is very important. It has to be little interior, it has to be square, and the tunnel should be made little longer. So this is very important, because if you make a longer tunnel, then you will have a lesser propensity for the iris to prolapse out of the incisions. Must use very high viscosity OBD to pressurize the iris away from the cornea, so that posterior pressurization of the iris should be done, and that can be done with the high viscosity OBD. And during the surgery, you must use very low vacuum, low flow, and low water height, so that you don't create too much of the pressure within the anterior chamber. So vacuum of 200 or aspiration of 26 ml per minute would be very sufficient vacuum and to continue the surgery. So this, you can just see this video, because this is the video where we have already done all these procedures. We have made a long tunnel, we have given the intracameral injection, we have used high viscosity adaptive OBDs, low fluidics, and all these parameters have been taken care of. And since the pupil dilated around 4 millimeter before the surgery, I decided to continue the surgery. So I'm trying to create a capsulorhexis, and you can very clearly see, like, I'm able to create a capsulorhexis of around 4 millimeter in this particular case. This patient was on tamsulosin for a pretty long time, which we stopped at least a month before the surgery. And but what you can see now, because the moment I start hydro procedure, and trying that, the pupil has started slightly constricting, and you can see the movement of the iris, the belonging, like the forward and backward movement of the iris. And the moment I'm trying to rotate the nucleus, again, the pupil is going further smaller. And when I enter the phaco into the eye, because the nucleus was quite hard in this particular case, and see the iris has started prolapsing through the side port. I'm using the terminal chop technique here, because I'm using this terminal. I never use these sharp choppers. This is a blunt chopper with the inner wedge edge. And you can see, because very beautifully, I'm trying to, because what I was thinking was, like, if I can break this nucleus, I'll continue the surgery. Otherwise, I'll go in for the expanders or the hooks or expanders. But you can see very clearly, like, I'm able to break the nucleus. I'm able to break the nucleus, going around the equator of the nucleus and trying to break the nucleus. And I got a piece, one of the segment out of the capsular bag, and able to emulsify it. And the only important point is your phaco probe and the whatever device you use, it has to be at the center of the pupil. Don't touch the iris from any point of time. And so I'm very nicely able to emulsify these nuclear pieces and able to complete the surgery, emulsification. The aspiration of epinucleus as well as the cortex is going to be a little difficult, but then when you use a bimanual, helps you a lot, because bimanual, you can go underneath the capsulorhexis, underneath the pupil, and very safely you can hold the cortex and aspirate. So you can see here, because somehow I'm able to complete the surgery. Lens implantation is going to be a little difficult, because you have a lesser view of the rhexis as well as the capsular bag. But then important point is your leading haptic should be inserted within the capsular bag. So if you are able to put the leading haptic into the bag, then you can very nicely dial the lens into the capsular bag. So this is how I could complete this particular case without using any expanding devices or the hooks or the rings. But then, what are the key points for the decision for making to use a dilator or or the expanders. So you need to look at the pupil diameter, type of the cataract, biomechanical properties of the iris tissue, and surgeon's skill. So in this situation, you have a lot of expanders available now. The best what I find is the use of the hooks. So I'll just show you this video, the hooks, how this again a very small pupil of less than 3 mm pupil. So I'm going to use the iris hooks for this particular case. The only important point in iris hooks placement is like when you are using the iris hooks, just place all the 4 hooks within the anterior chamber without stretching it first. Just put all the hooks inside, place all the hooks inside, and then you can stretch one by one slowly so that you expand the pupil. So this is how you can get a pupil of around 4.5 mm or 5 mm pupil, and then you can complete the surgery. Just the last video, because the expanding devices, the Malaysian ring is very commonly used, and this gives you a much better exposure of the anterior capsule. You can get a pupil of around 5.5 mm pupil, and so that your surgical procedure becomes much better. The only problem with this is because the placing and the removing the Malaysian ring is not very easy, because you have to be very uh, careful while injecting it, because sometimes this may lead to the too much of stretching of the iris, and you may get the sphincteric tear, and you may get this kind of bleed in the eye. But then you can see finally, like, you get a very large pupil of 5.5 to 6 mm, and you can very easily complete the surgery in this situation. So I'll just take the last, okay. So to conclude, in small pupil cases, particularly in IFIS, stepwise approach gives safe and better results, because you can go ahead without putting any expander if you think that your pupil is sufficient to complete the surgery. Most of the time, simply using intracameral mydriatics and high viscosity OVD, we can complete the surgery successfully. Two main drivers for the decision to use pupil expander devices is the size of the pupil and the biomechanical properties of the iris. That you should know that what kind of biomechanical property this particular case has. And using these devices would definitely outweigh with the safety issues of the pupil expander than continuing the surgery in a small pupil. Thank you very much.